Prashant sir, welcome.
Good evening, Mohan.
Okay.
Good evening.
It's already live streaming. Okay.
Mohan, video on cheyo.
I'm driving. I'll reach now. 5 minutes.
Driving. Okay.
I will make you co-host.
Co-host operational logistics I am very poor. That is the issue.
നമുക്ക് 5 മിനിറ്റ് ഉണ്ടല്ലോ.
സമയമുണ്ട്. എവിടെ വരെ എത്തി?
ഞാൻ വൈഫിനെ ഒന്ന് ഡ്രോപ്പ് ചെയ്യാൻ പോയതാ. ഇപ്പൊ വരും, കുഴപ്പമില്ല.
ഓക്കെ, ഫൈൻ. നമുക്ക് 5 മിനിറ്റ്
എന്തായാലും വീഡിയോ ഓൺ ചെയ്യുന്നില്ല. ടൈം ഓൺ ചെയ്യാം. എല്ലാവരും എത്തട്ടില്ല. ഐ ആം പെർമിറ്റിംഗ് എവരിബഡി ഇൻ. ഓക്കെ.
Geeta madam, good evening.
പ്രശാന്ത് സാർ, ഞാനൊരു ലിങ്ക് അയച്ചിട്ടുണ്ട് പേഴ്സണൽ ചാറ്റില്, സൂമിന്റെ പേഴ്സണലില്. അതാണ് യൂട്യൂബ് ലിങ്ക്.
അല്ല, അത് മോഹൻ ഇപ്പം അത് ഗ്രൂപ്പിൽ ഷെയർ ചെയ്യണ്ട.
അല്ല, അത് ഇടുന്നില്ല. ഐ എം സെൻഡിങ് ടു യു ഓൺലി. ഞാൻ വേറെ ആർക്കും കൊടുത്തിട്ടില്ല.
അതല്ല ഞാൻ പറഞ്ഞത്, നമുക്കത് ഇത് എക്സീഡ് ചെയ്യുകയാണെങ്കിൽ മാത്രം ഇട്ടാൽ മതി.
ഇത് കുഴപ്പമില്ല. ഞാൻ എന്തായാലും ചെയ്തു വെച്ചതേ ഉള്ളൂ. ഇതൊരു മനക്കേടാണ്. അത് ശരി,
മനസ്സിലായി. ആ സമയത്ത് ചിലപ്പോൾ പാടായിരിക്കും സ്വിച്ച് ഓവർ ചെയ്യാൻ.
അതന്നെ എനിക്ക് ആ സമയത്ത് പറ്റിയില്ലെന്ന് വരും. 5 മിനിറ്റ് ഉണ്ടല്ലോ. രുക്മിണി മാഡം, മാഡത്തെ ഒന്ന് വിളിക്കോ? രുക്മിണി മാഡം.
ഗുഡ് ഈവനിങ് മാഡം.
Good evening.
വിജയകുമാർ സാർ, ഗുഡ് ഈവനിങ്.
Hello,
good evening. Prashant, കേൾക്കുന്നുണ്ടോ?
Good evening, sir.
Good evening.
Good evening, Dr. Prashant. Good evening.
Good evening, madam. Madam, is it raining heavily there in Chennai?
No, just cloudy.
Cloudy. Okay. Here in the northern part and central part, it is raining heavily.
Thing or the other, either raining virus or raining rain, something raining.
I've already made Bharati madam co-host. You can try sharing the screen, madam.
Okay, I'll try. Okay.
Geeta madam, good evening.
Good evening. Can you hear me?
Yes, madam.
Okay.
മഴ കുറഞ്ഞോ അവിടെ?
കുറച്ചു നേരത്തിന് I'm sure it will start raining again.
Okay. വീട്ടിലാണോ മാഡം? വീട്ടിലാണോ ഹോസ്പിറ്റലാണോ? വീട്ടിൽ.
വിജയകുമാർ സാർ, മഞ്ചേരി എക്സാം ആണോ MBBS?
മഞ്ചേരി എക്സാം ഇപ്പൊ കഴിഞ്ഞു ഇവിടെ എത്തിയിട്ടുള്ളൂ.
ഓക്കെ. കാലിക്കറ്റ് എത്തിയോ?
കാലിക്കറ്റ് എത്തി, ജസ്റ്റ് അങ്ങോട്ട് കയറി.
ഓക്കെ. നമുക്ക് ഇനി വെയിറ്റ് ചെയ്യാം. കുറച്ച് പേരും കൂടെ വരാനുണ്ട്. എനിക്ക് തോന്നുന്നു ഇഫ് ഇറ്റ് പെർമിഷൻ ഓഫ് ദ നമുക്കൊരു 5 മിനിറ്റ് നോക്കാം.
Yes, no problem.
Now you can see the screen, no?
Yes, ma'am.
Yeah.
Clear, ma'am. You can move the slides, ma'am. Yes, ma'am. Clear.
Yes. Very good.
Okay. Sir, second speaker.
Srinivas.
Second speaker, Dr. Srinivas.
Srinivas is
No,
joined.
he can also try. I will also make him co-host.
He has not joined.
Okay. They will be familiar with this, so no problem.
Dr. Srinivas has admit.
Join ചെയ്താ.
Dr. Srinivas has come.
Co-host ആക്കിയിട്ടുണ്ട്. പ്രശാന്ത് സാറിന് അഡ്മിറ്റ് ചെയ്യാം.
I have admitted. Admitted.
2 മിനിറ്റ് കൂടെ നോക്കാം.
Yes, yes. Is Dr. Srinivas joined?
Yeah, yeah.
Yes. He can also share.
That's a superhero DP. Advait's its sons. Sin fire. It's sin.
Hello, Dr. Srinivas.
Nivas, you or your son or your daddy is there.
I know him also. He is
Hello,
studying in
madam.
Calicut. Hello, Srinivas.
இல்ல அத்வைத்தோட இது வருது.
Hello, Dr. Vijay Kumar.
Hello.
Hello.
Hello, Srinivas.
Yes. Am
இல்ல
I audible?
அத்வைத் நேம் வருது, அதனால எந்த ஜெனரேஷன் இப்போ இருக்கீங்கன்னு பாக்குறோம்.
Okay. Now, is it okay?
Yeah,
Yeah,
you
Srinivas.
I have renamed myself. Am I audible?
Yes, audible.
രുക്മിണി മാഡം വന്നിട്ടുണ്ട്. I will admit her.
Admitted.
Hello, Srinivas.
റിയാസ് സാർ വരാനുണ്ടല്ലേ?
Dr. Vijay Kumar,
He
Calicut.
has joined.
Oh.
He has joined.
आज लाना पड़ेगा.
Sir,
How are
very
you?
nice to see you, sir. Very, very good. Very happy to see you, sir.
How are you doing? Fine.
Very good, sir.
Yeah. I just came to see your class. This program.
मैंने.
സാറിനെ പഠിപ്പാൻ നമുക്കൊന്നും ഇല്ല സാറേ. സാർ എല്ലാം അറിയുന്ന ആളല്ലേ?
It's nice to see you here.
Absolutely, sir.
സുഖം തന്നെ?
Absolutely.
സുഖം തന്നെ. മലയാളം മറന്നോ?
ഇല്ലേ, മലയാളം എങ്ങനെയാ മറക്കണ്ടേ? ഭാര്യ പിന്നെ മലയാളം.
We taught him Malayalam also from Calicut.
and gave him and the wife also.
Yes.
രുക്മിണി മാഡം.
Yes, I am here. Good evening.
Good evening,
madam.
Good evening, everybody.
Good evening.
Riyaz sir join ചെയ്താ?
ഇല്ല. ഒന്ന് വിളിക്കോ?
Sir is having another talk at 7 o'clock.
റിയ സാറിന് ഒരു പ്രോഗ്രാം കൂടെ ഉണ്ട്.
PG Club.
PG Club in കോട്ടയം.
Okay.
വോള്യൂം കുറയ്ക്കാൻ എന്തെങ്കിലും അതെങ്ങനെയാ കുറയ്ക്കണ്ടേ വോള്യൂം?
Volume, there is a scroll bar on the side now.
ഇപ്പൊ സംസാരിക്കൂ.
Clear? Is it clear?
Yeah. I think I reduced the volume on my laptop.
Yeah. It is okay now. Clear.
Yeah.
I will start recording once the meeting starts. Okay.
Okay. ലളിത മേഡം ജോയിൻ ചെയ്തില്ലാന്ന് തോന്നുന്നു.
ഇപ്പൊ പ്രശാന്ത് ഒരുപാട് IBDs ഉണ്ടല്ലേ കേരളയില്? കേരളയില് നിറച്ച് IBD ആണല്ലേ?
Srinivas ഇടയ്ക്ക് കാലിക്കറ്റില് വാ.
തീർച്ചയായിട്ടും സാറേ, ഞാൻ തീർച്ചയായിട്ടും വരാം.
Can come Monday അല്ലേ?
വരണം എന്നൊക്കെ ആഗ്രഹമുണ്ട്. തീർച്ചയായിട്ടും വരാം. കുറെ കാലായി അവിടെ വന്നിട്ട്. നമ്മുടെ കോഴിക്കോട് കോളേജ് കണ്ടിട്ട് കുറെ കാലായി.
യെസ്, ഒരു ദിവസം വാ. അല്ല, കുറെ ചേഞ്ചസ് ഒക്കെ വന്നിട്ടുണ്ട്.
ഓക്കെ, ഡെഫിനറ്റ്ലി സർ.
Prashant Rimjim has joined.
Madam, she has joined.
Good evening, ma'am.
Good evening. Good evening. Rama.
Good evening, Dr. Prashant. Hello, everybody.
Good evening.
ഹലോ.
Good evening.
Good evening. Good evening.
Ah,
Meghna has come.
Good evening, ma'am. Malti, ma'am.
Yes, good evening.
Ramaji, vanakkam.
Hi, Srinivas. How are you? Vanakkam.
Ramaji മാറിയിട്ടില്ലല്ലോ അതേപോലാണല്ലോ കാണാൻ.
Thanks for the compliment. 20 കൊല്ലം ഏജിങ് ഒക്കെ നടന്നുണ്ട്. Anyways.
Hello, Rama.
Hello. Hello, sir. Are we waiting for somebody?
Shall I start recording?
I think we can start.
ലളിത മാഡം ജോയിൻ ചെയ്തില്ലേ ഇതുവരെ? മാഡം ഈസ് മാഡം ലളിത മാഡം ജോയിൻ ചെയ്തു.
Megdeep, Jaya.
സോമശേഖർ
Evening, Somashekar has come. I think so. Quite a number of your Vispagan people have come.
യെസ് മാഡം.
Good evening, madam.
Evening, Somashekar.
Good evening.
സോമശേഖർ, ഗുഡ് ഈവനിങ്.
Hi, Prashant. Good evening.
Can you put on the video?
One sec. There's something.
Jaya also. Jaya is Jaya. Meghna also can put the video.
Shall we start?
Yeah.
I think we can start by the time. Mohan.
Yeah. So, good evening, everybody. Myself, Dr. Mohan Chinoy. I work as a consultant endocrinologist and as a pediatrician in Trivandrum Sri Gokulam Medical College. I am also the Joint Secretary of IAP Tirunelveli branch. It gives me great pleasure to welcome all of you to this special webinar. This webinar on the day of World IBD Day 2022, jointly organized by the Division of Pediatric Gastroenterology, Department of Pediatrics, SAT Hospital, that is the Government Medical College Tirunelveli, along with the IAP Tirunelveli branch. It is also part of the IAP Promise, which is the Presidential Action Plan. So with this, I think we'll have to get the speakers as well as the host welcome. So let me welcome the host of the presidential address, Dr. Rukmini Madam, President of IAP Trivandrum. Rukmini Madam, please.
Audio is not clear.
Respected, see, I'm outside. Can you hear now?
Yes, ma'am. Yes, ma'am.
Respected State President Dr. M. Vijay Kumar, Dr. Rama Krishna Kumar, Chairperson Pediatric Gastro Chapter IAP, Dr. Riaz, NIBM CIAP, Dr. Kalpana, our Vice President IAP Trivandrum, the speakers Dr. Malati Satyashekaran, Dr. Srinivas Shankaranarayan, and the chairs of the day, my own teachers, Lelita Madam and Dr. Geeta, the gastroenterologist from Chennai. Namaste. Then IAP Trivandrum is happy to join organize the World IBD Day webinar along with Pediatric Gastro Department, SAG Trivandrum, under the leadership of Dr.
Your voice is
Raising
breaking.
Madam's volume. Yeah.
Prashant,
Madam, your voice is breaking
who is
actually.
moderating today. Please continue.
Mohan,
Yes, yes, yes.
Mohani, will you?
there is some issue, I think.
Madam has to stop. Then only we can interfere. Ma'am.
I have stopped.
Madam is there.
So you can continue. Thank you.
Madam, conclude Mohan, conclude
Okay, yes, yes, madam. Madam, actually, apologize for the,
Concluded.
yeah. Okay. Thank you, madam. So I think with
Thank
this, yeah, thank you, madam. With this, I will just welcome everybody today. I think we have got the inauguration. Inauguration will be by Dr. Rama Krishna Kumar, madam. Madam is a chairperson of Pediatric Gastroenterology Chapter at IIP Kerala. Madam is working as a senior consultant in Maulana Hospital. Please, madam, over to you.
Thank you so much, Mohan, for the kind introduction. Thank you. Respected seniors and friends, it gives me immense pleasure as the president of the Pediatric Gastro Chapter of IIP Kerala to inaugurate this well-timed symposium on IBD in association with the World IBD Day. We have two eminent speakers, Malati Satyashekaran ma'am. She is well known to all of us, the doyen of pediatric gastroenterology in India, one of my teachers too, and Dr. Srinivas Chandranaran. My acquaintance with him dates back to almost 20 years from Calicut Medical College days when he used to be a PG and me too. And so both of them are very eminent speakers, and we have two very appropriate topics: early onset IBD and biological IBD as the topics today. And kudos to Dr. Prashant, pediatric gastroenterologist, for organizing this meeting, and looking forward to a lovely academic feast. Once more, I have great pleasure in inaugurating this evening's meeting. Thank you, one and all.
Thank you, madam. So next agenda would be felicitations, and it will be by in sequence Dr. Riaz. Dr. Riaz is the NEBM CIAP 2022-2023. Dr. Riaz sir, as reached Dr. Prashant.
He has not joined.
Is not joined. So I think we'll welcome Dr. Kalpana madam, who is the Vice President of IAP Trivandrum. Kalpana madam.
Madam has also not joined.
Okay, I think it's honor for me to invite you, Dr. Prashant. Dr. Prashant sir, please can you just introduce the topic of felicitation?
First of all, let me thank my home branch, IIP Trivandrum, for extending an opportunity to organize this webinar on the eve of World IBD Day. And today we have actually two topics. One is on very early onset IBD, the other is on biologicals in pediatric IBD, step up or step down. As already mentioned, we have two eminent speakers. For introducing the first topic and the speaker, may I invite my teacher, Lilita Kailas madam. Over to Lilita Kailas madam. Madam?
Yes, I can hear you.
Thank you, madam.
Okay, esteemed faculty member, Dr. Malati Satyashekaran and Dr. Prashant, IAP officials, I can see only Dr. Mohan here and Dr. Rukmini, and of course the state president, Dr. Vijay Kumar, and the viewers. A very warm actually, though it's cold, a very warm good evening to all of you. And I'm extremely happy to be a part of this webinar organized in connection with the World IBD Day today. And thank you, Prashant, for the invite. The inflammatory bowel disease, as we know, it's actually a chronic debilitating illness. It's mostly, I think, to our knowledge, it's mostly seen in adults, but it used to be. But nowadays, we are seeing more and more cases in pediatrics as well. It's actually a dysregulated immune responses to environmental triggers and a genetically susceptible intruder. So that means all the three factors are there. And though, as I said, it is mostly in adult, but nowadays we are seeing roughly around 20 to 25% of the cases occur below the age of 18. But more important is that roughly 4 to 6% occurs, and that too below the age of 6 years. So that is, here comes the importance of this very early onset IBD, that is when it occurs below the age of 6 years. And because it occurs so younger age, it is associated with more morbidity, and also because of the longer duration, much sequelae also. And also it is mostly associated with the genetic basis, and at least significant chunk is associated with immune deficiency, primary immune deficiency. So how to make a diagnosis, how to treat and all, I think it's still a dilemma. So to deliberate or enlighten on this particular topic, we have Dr. Malati Satyashekaran with us. Really fortunate to have such an excellent faculty on this IBD Day. Dr. Malati Satyashekaran, you know, she's a very well-renowned pediatric gastroenterologist, now working as a senior consultant pediatric gastroenterologist in MGM hospitals and Kanchi Kamagodi Trust Hospital. And she actually did her MBBS from Kilpack Medical College, followed by DCH in CMC Vellore, and then NT Pediatrics from Madras Medical College, and then DM in Oncology as early as 1986. And during her, she has an excellent academic career. That means she must achieved or gold medal in almost all the subjects in the MBBS, that is including medicine, surgery, and the best outgoing student in most of the, I think, both her UG and PG days. And after her post-graduation, she has joined as a DM, super specialty, joined as a faculty in ICH, that is Madras Medical College, till about 2020. And now she's the senior consultant working in that MGM Hospital and Child Trust Hospital. And I think her accomplishments are long. And if I'm going to say everything, I think it will take more than an hour. So I'll just cut short it briefly. She has so many, there is around more than 75 international and national publications. She has contributed chapters to many of the prestigious textbooks, and a well-known or sought-after speaker in many of the international and the national conferences too. And even she has delivered many orations, and I think, let me say, I think one of the academic societies also she had adorned certain positions, like president in Indian Society of the Pediatric Hepatology and Gastroenterology. Much more than that, that is, though, in spite of, other than being an academician par excellence and a clinician par excellence, I'll say that she's a very simple, practical, and a very approachable and friendly pediatric gastroenterologist. So we really consider ourselves fortunate to have you with us, Dr. Malati, today to deliver. And with this, I invite you to for your deliberation. Over to Dr. Malati.
Thank you, Dr. Lalita. Thank you, Prashant, and all of you for this warm welcome, Dr. Vijay Kumar, Dr. Rukmani, and the others name by name. Dr. Yes, I think everyone has joined, especially Rema and my co-speaker. It is indeed a great privilege, because I always feel such a hospitality I receive when I come to Kerala. All the chapters, I just enjoy coming there, and though we are not able to meet physically still, I like to be here, and I'm so happy that on IBD Day, Prashant takes all the thing and then he's arranged this meeting. So today my topic is a very early onset IBD. Dr. Lalita has given a very nice introduction clearly she's told you about the pathogenesis. She's spoken about the percentage of pediatric IBD and also the definition. I'm going to share some of the thoughts about very early onset IBD because the audience are more pediatrics. I'm going to the basics and I'm sure we will have some good interaction. And thank you once again for inviting me. So very early. So my first encounter, though I had seen patients of Crohn's earlier, like Dr. Alita was saying, they were much older. So it was in 2000 when I was in Children's Hospital, I first saw this child, a 4-year-old child who was referred from me from the Department of Hematology at that time, because constantly this child was developing oral ulcers at dysphagia, and they kept on doing HIV testing, and the mother was so upset about that, but still she came, and then we did endoscopy and we diagnosed as Crohn's disease, and to this child's fortune and our luck, the child did very well. In 2005, we saw this child, a 4 years, 6 months boy, presented with a palatal ulcer, fever, and loss of weight. And so this first case, we published it in Indian Journal of Pediatrics as Crohn's disease presenting as palatal ulcer. So something we were seeing new, something different, presentation was different, their way they responded was also different. And so this very early onset IBD is what I'm going to talk about, a distinct phenotype in pediatric IBD. I will be covering the topics under these headings: definition, incidence, and etiology. Phenotypic features of very early onset of IBD. Are they different from older age of onset IBD? Because the topic is very early onset IBD, I'm going plump on the topic PEO-IBD rather than telling you about PIBD, because as the way Dr. Lalita was talking about PIBD, I'm sure that you all know the basics. You know all that about PIBD. And so now we are going to take you to this smaller group of very early onset IBD. What is the differential diagnosis? Why should you know about very early onset IBD? And then what is this, why, when, how to diagnose this monogenic IBD which comes into this very early onset IBD? Then talk a little bit of management and conclusions. So term very early onset of IBD is only about a decade old, because we all know pediatric IBD is classified to differentiated from adult onset IBD. Anyone whose age of onset is less than 17 years, anyone that group, now we take it as 18, is pediatric IBD. In 2012, Muse et al. Said early onset IBD, he called it when the onset was, the child was less than 10 years of age. And then they also said very early onset IBD when the child was less than 6 years of age. So very, this good classification. Why should we classify? Why can't we clump everyone together? Just call it pediatric IBD. Pediatric IBD itself is something some people say, do children have IBD? The question is still there in some parts of our country itself. Then keep on dividing them more and more and more. There is a purpose and there is a reason for this. So the definition for a very early onset IBD is, as I told you, it's a subset of pediatric IBD where the onset of disease is less than 6 years of age. So this, I think, should be very clear. It is less than 6 years of age. What does this include? It includes a very unique and complex subgroup of children, potentially phenotypically and genetically different from the older age of onset groups of PIBD. That is the reason, because it includes a very important set of phenotypically and genotypically different from the older age of onset. So this very early onset of IBD, not to confuse us more, to make it little more clear, it is again classified into infantile and neonatal. Now look at this. Why was this classification necessary? It is not to confuse pediatricians, not to confuse gastroenterologists, but because these groups behave differently. We have to know these behave just like, they have preterm, then they have primaries, and they have more. Like that, when they can divide like this, we can also divide. Very early onset of IBD, the two main reasons are their behavior pattern of either presenting as Crohn's or UC is not very definite. So that 20% present as IBDU. That means when you look at the colon, it will look like ulcerative colitis, and you may see a microgranuloma, or it may look like Crohn's, and then the histopathology comes as your cryptitis and ulcerative colitis. So this and the monogenic IBD is high from 0 to 33%. Whereas when the child is becoming younger and younger, when the onset is less than 2 years of age, the IBDU diagnosis becomes higher. We all know pediatric IBD, there are Crohn's disease, ulcerative colitis, and 10% where it is in between, where we call it as IBDU. So IBDU becomes more, the proportion of IBDU becomes more as the onset of disease is younger and younger. And monogenic IBD is much higher than in the BEIOBD infantile. It can go up to even 40%. Then you have the neonatal IBD, which is a separate less than 28 days of life itself. If IBD starts in an infant, you call it neonatal IBD. So this, I think, should be very clear. Very early onset IBD, less than 6 years of age onset, and higher IBDU, and they have more monogenic IBD. Whereas if the disease, you see a child who's less than 2 years of age, you must see their presentation may be like UC, but when you look at it, may like Crohn's. And monogenic IBD is higher in this group. Therefore, the investigations change in this group. This is what I'm going to tell you as I go by. So this is the definition. Now I think you're very clear. What is the incidence and etiology? As Dr. Lalita was saying, this is not very common of all the PIBD. This was a study where Dr. Srinivas is here, Dr. Geeta, all of us were there in this group. It was a questionnaire study only, but it was one of our early presentations, and it was published in 2014. We had 21 cases, and when we analyzed that group, we found less than 5 years, 13% of our children in India itself were less than 5 years of age. Then the next study was published recently in 2020. The previous study, we had only 7 centers. Mainly it was from South, one only was from North. Here we had centers both from North and South, 9 centers. Instead of 221, we had a higher number, 325 children from India, published in 2020. And look at this. This analysis was little more definite because now the publications were all coming up. We were also very clear about this definition because earlier, this less than 10 years itself was called as early onset IBD. And you know, there was a confusion of the numbers. So now it is very, very clear. It should be a universal definition so that we all speak the same language. So if I talk about very early onset IBD, the people from UK also must be thinking of children less than 6 years of age. They should not be thinking of children less than 10 years of age. So this is very clear. So this study, we were very sure. We did not classify it as less than 5, less than 10, but we made it less than 6, and we had 19.3%. You might think whether it's increasing over time. The study was not done to show it is increasing over time, but there are this type of study where it is a population-based retrospective cohort study, which was published from Canada, which clearly showed that yes, very early onset IBD is increasing over the years, 6 to 9 years, 7.4% annual yearly change. It is increasing over time. Though in our study also it is showing, but it's not done in that, but the numbers are showing. What is this? Awareness will be increasing. Pediatricians will start picking up cases even at the age of less than 6 years. They will start picking up less than 2 years, and they will refer to a pediatric gastroenterologist. So this awareness that over time, this group seems to be increasing more than that group with the older age onset. This is what I want to stress. More than the older age onset, this was one of the publications. And pathogenesis, I think beautifully Dr. Lalita said, the Venn diagram which we all teach, it is an interaction between a genetic susceptibility, it is a dysregulated immune balance. That's what she was saying, a dysregulation of immune response. And then she said about the antigens. It may be an antigen in the environment or internally. And this is called that. And most of the cases The genetic susceptibility in the classical IBD, which we were teaching, which we learned, is all polygenic. That is, GWAS study, genome-wide association studies have shown 240 IBD-associated genetic loci, and these are all polygenic. So this is the one. This is the Venn diagram which we draw for all the PIBD. But what is happening? I was telling you, monogenic IBD is more in children less than 6 years of age, and it is higher in children less than 2 years of age. So the same Venn diagram for a VEO-IBD, a little different. So you just make 2 wings of the genetic, and you remember that if you do other studies, you will be finding that monogenic IBD, if you do the next generation sequence studies, or you do whole genome studies, or you do the whole exome studies, you will find that there is a group of single gene, rare genetic disorders in this group of very early onset IBD. So the same dysregulated immune balance, some change in the environment, the internal environment where the gut microbiota is playing a big role, and you have the monogenic IBD coming up higher and higher as the age of onset becomes younger and younger. So now definition is very clear. You know the incidence is increasing, you know the pathogenesis. Phenotypic features for very early onset IBD, are they different from older age of onset of PIBD? Are they different or are they not different? Have studies been done? Yes, studies have been done. It's a very good study which was published in 2014, again from Australia, where they showed 30 children where they compared, and the comparators were 60 children, and they said that those with late onset IBD, 6 to 18, 60, and early onset less than 60, that time they were calling less than 6 years as early onset. So recently only everything has changed. What was the difference? When they looked at the ulcerative colitis, they found that UC was more in children less than 6 years of age compared to Crohn's disease. That was a finding there. Blood in stools was also more common. But in Crohn's disease, isolated colonic, this is an important finding in children younger than 6 years. What happens is when you get isolated colonic involvement, you always assume, could it be a Crohn's ulcerative colitis rather than a Crohn's colitis? But even Crohn's isolated colonic involvement rather than ileocolonic is seen in younger children. Their presentation is more colonic than ileocolonic, and therefore you get more blood in stools, and this was statistically significant. The same thing was came from North America, 1,928 children, and they divided 1 to 5 years, 6 to 10 years, 11 to 18 years. They also found the same thing. In CD, isolated colonic is important. This response to therapy was not very different when it was a classical IBD. Steroids were being used 5 years post-diagnosis. There was no difference between the 3 groups. What about India? What did we see? In the study which was published, was found that very early onset IBD, we had 19%, I was telling you. IBD-U seemed to be very high in our group. It's not known the reason. Abdominal pain was not much compared to the older age group. As mentioned earlier, blood in stools was more in the younger group. And the pancolonic involvement, as mentioned earlier, was seen more in Crohn's disease. So there is some phenotypically difference. Normally what we say is in pediatric IBD, ileocolonic is more common than isolated colonic. That is the usual pattern. And abdominal pain can be seen, but the younger the children, pain may not be there. Blood and stools may be there, but Crohn's disease is usually a colonic presentation. So there are some important features of very early onset IBD. De-stressing, bleeding PR is more common. Ulcerative colitis, it is more a pancolitis. You rarely get just a distal proctocolitis or a left-sided colitis. In Crohn's disease, the colonic involvement is more. Fecal calprotectin, what we usually talk about, a non-invasive marker which has been used both for follow-up and sometimes to differentiate between irritable bowel syndrome and for IBD, is not sensitive nor specific when the child is less than 6 years of age. This is a very important point we should remember, because the cutoffs for this age are not very definite. And so we have to be very careful to use fecal calprotectin as a diagnostic marker. And the other one is for imaging, which is always recommended for children with PIBD. If you suspect PIBD, you must do endoscopy, upper GI, you must do ileocolonoscopy, and you must do small bowel studies unless you are very sure it is only very classical UC. When it's suspected IBD, you're supposed to do. But when you do a small bowel imaging, the younger the child, you tend to expose them to anesthesia, radiation, and therefore we should be very sure. So these are the problems. So phenotypical of very early onset IBD, I would like you to, imagine it like this. Less than 6 years of age, take less than 2 years separately, take 2 to 6 years separately. In the 2 to 6 years, you have both polygenic and monogenic IBD. In less than 2 years also, you will have polygenic and monogenic. The monogenic will be very high in less than 2 years of age, whereas it may not, it is also high, but less than this. So this is very, very important. So if you have a pie diagram of very early onset IBD, the classical will be around 80 to 75% to 80%, whereas the non-classical or the monogenic IBD, this is that small chunk which we have problems with, will constitute 20 to 25% on the whole. But if they are less than 2 years, it might even become higher, 40 to 50%. So now your thing, the definition, the incidence, the pathogenesis. This very early onset IBD has some different phenotypic features, and think you are clear about this. So what is the differential diagnosis? Do not forget infections in our country. I'm sure Dr. Srinivas will agree. We've seen even, CMIV in a immunocompetent child. He has reported that. We've seen that. And so every time you keep this in mind, don't just dump saying it is IBD. It is very early onset IBD, because once you label a child as very early onset IBD, it's lifelong. But suppose you get something where we picked even amoeba. I don't know whether he remembers. It was very surprising. We thought it would be ileocecal, and then it was amoeba. Allergic colitis, recently, CMPA, less than 1 month of age. I had 2 babies who presented with FIs. They were so sick. That is, they were so sick in the sense, hypoalbuminemia, we had to give them blood, we have to give them albumin. I was a little concerned because the baby was also on breast milk. So we even did the clinical exome sequencing, and we were happy that, the baby did not have any of the ones which we thought about. None of the monogenic disorders. Done the sigmoidoscopy, I had done endoscopy, I saw the apnoid ulcers, and both the babies are doing very well with the amino acid formula. So we have to be very clear when they present with this small group, a severe CMPA which resembles a monogenic IBD. That group you have to identify, and they will do well just with medication, with this change of formula, and slowly we can introduce. Eosinophilic colitis is now coming up in a big way. You call this as EGID, and we have specific eosinophil count per everywhere, from the stomach, certain amount, duodenum, this amount, that amount. And in our country, we have to be very careful because of the parasitic. But we are now picking up this because of the colonoscopy procedures we are doing, and because of the biopsies and the histopathology. Behçet, celiac disease, do not forget, though we are not seeing both Kerala and Tamil Nadu, it's less, but now because of this inter-state marriages and travels, we are picking up few more cases. So very early onset IBD, as I told you, is definitely a distinct phenotype. The DD. Now, what is this monogenic IBD? Now you are clear about polygenic IBD. What is this monogenic IBD we are talking about? What is this monogenic IBD? Monogenic IBD is actually a group of rare Mendelian genetic disorders. The single genetic disorders, actually, they are all immune deficiencies or epithelial barrier. To tell the truth, they are not in our purview. They are not actually problems of gastroenterology. They will either go to the immunologist or they will have to go to the hematologist, because the treatment is completely different. That's what sometimes you're saying. They will, after a few years, I think they will take off this from our thing. It's not ours. but still their presentation has a GI presentation. So some of them come to us, but many of them go first to the hematologist and we get referrals from them when they get the loose stool. But they have different penetrance and they all present with IBD-like inflammation. That group of single gene Mendelian disorders with IBD-like presentation are known as monogenic IBD. Not all immune deficiency states, but when they present with IBD-like inflammation, when we do a procedure, we've seen something, then we get it. And what will be the proportion? I've already told you, 25% of VEOIBD will be MD, and it will be higher when it is infantile onset IBD, it can go up to 40%. After the age of 7 years, this rapidly declines. Why is this very important? That is, when we start investigating, you need not investigate after a certain age. All the exome studies, all that you need not do for a certain age. When there was one study recently by Crowley, I will show you 2020, where they've analyzed 1,000 cases of pediatric IBD. I will show you the percentage they picked up. Total, if you do for 17, all the till the age of 17 years, only 3% will have MD. So why is this important, MD? The younger they are, especially the infantile onset monogenic disorder, very aggressive, severe inflammation. They will not respond to your conventional treatments. No use pushing higher. Give steroids, not responding. Give biologicals, it will not respond because the etiology itself is different. High morbidity, high mortality. And this group itself needs a very different approach from the classical IBD for diagnosis and treatment. So this was the study I was telling you, published in 2020, where this group have analyzed a multi-center trial, 1,005 children, all the 1,005 children of PIBD, they did the whole exome sequencing. Just imagine doing for all. We can't even do it for one child in our country, but they did it for all the children. And they found when the children had the disease less than 6 years of age, a monogenic disorder in this study is only 7.8%. But when it was 6 to 18, it is only 2.3%. Totally, they said only 3% had MD. So this monogenic disorders are around, there are 6 types. You can just remember it like that. These are genetic variants which will either, it is the integrity of the intestinal barrier of the intestine, and therefore they get prone to that. I will show you the most important will be either GUCY2, we have a case which we'll be showing you, or TTC78, or it will be a bacterial recognition and therefore they get an IBD like inflammation. Remember, most important, chronic granulomatous disease where they cannot recognize the bacteria. The most important is this defect in the cytokine clearance, this IL-10, IL-10R. Why is this important? This mutation is very high in Asia and this has 100% penetrance. So if a baby is born with IL-10 or IL-10R mutation, they will have IBD-like features. They will pass blood and mucus in stools, and I will show you with their presentation. They will have colonic ulcers and they will respond not to your steroids, not to azathioprine, not to biologicals. Though we say perineal fistula, you give biologicals, you have to push them straight to hematopoietic stem cell transplant. So IBD, gastroenterologists have to refer to the hemato-oncologist for transplant. Or it can be impairing of regulatory T cells, or it can be an autoinflammatory or adaptive immune system like SCID or CVID, which you all know. So these are the main groups of disorders which can present as monogenic IBD. That means intestinal barrier for immune problems and bacterial recognition. Most important to remember, IL-10, IL-10R, or it can be innate immunity or adaptive immunity or regulatory T cells. The others, as the cases come, you can see and you can study. So the study here we published recently, Dr. Srinivas is here. We had analyzed, we looked only at infants less than 2 years of age with features of IBD. And we had 15 infants in 5 years. And we did 10 had genetic studies and 8 had confirmed monogenic disorders. And this was published recently. It has come out in May 2022 article. Out of that, 3 had IL-10, IL-10BR, and they've had their hematopoietic stem cell transplant. 1 had GUCYC2. So I will just show you this case of reports. We'll quickly go. I think we are short, we're running time. We have time. Yes, so this was a child. Just imagine this baby, birth weight 3 kilos, exclusive breast milk, till 6 months of age. So you would think, oh, nothing will happen to this child. Why should this child get anything? But at the age of 9 months, 6 months only, the mother started complementary feeds. Very well brought up, very knowledgeable mother. She did that. At 9th month, she noticed blood and mucus in the stools 3 to 4 per day, oral ulcers, perianal erythema, generalized swelling of the body, erythematous rash. When this child was brought to us, I was really stunned seeing this child. And you know, this child was looking all edematous, all swollen, puffiness. You think this is a child who is healthy, but actually it was anasaka. So I did the endoscopy, colonoscopy, and I was stunned seeing such long ulcers. Like, just imagine child having such ulcers. And I remember Srinivas and myself, we admitted the child in Child Trust, and then we gave albumin, gave him PRPC, and then the report came as cryptitis, cryptapsis. We couldn't get much. See, the ulcers look like Crohn's, and the picture histopathology came like UC. So we said, yes, it looks like IBD-U, but we did not know what it was. So we did a HIV negative. We looked at all the subsets. The routine is, when the infant is less than 2 years of age, always do, and you have IBD link picture, do the immunoglobulin profile after the age of 6 months, do the lymphocyte subset. Always do this. Then we sent for genetic analysis, and we found that this child had this epithelial barrier defect, which I was telling you about, GUCY2C. Why is this important to know this? Yes, this looks like a monogenic disorder. Why should we do clinical exo? Because the treatment, this child will not improve with hematopoietic stem cell transplant. Actually, it will become worse. So this is not a case for, though we say monogenic disorder, many will improve. I will show you who will improve. This child will not improve. This child will improve just with supportive treatment. I think we gave first we gave amino acid formula, then we came to extensively hydrolyzed formula, treating infections. Dr. Srinivas is taking care of this child, and this child is growing up, though there are issues. It's getting infection now and then because this epithelial barrier is not working. Intermittently, it is taking antibiotics, but we cannot do anything for this child. Probably later, I'm not sure whether all these things, because in the thing, these children can only manage with supportive therapy. Then the next case was this IL-10RB mutation case, which we saw and made the child presented at 7 days of life with perianal rectovaginal fistula. When the baby came to me at 7 months, actually I thought, it was just some infection and something. I didn't think much. So we gave some antibiotics, and then afterwards, few days later, then ear discharge, then a little bit of, blood and stool, the mucus. Then my eyes opened because the mother said, madam, previous sibling died of this. Then slowly we picked up very quickly. So we did the colonoscopy, and then we found a large ulcers, and this child had IL-10RB deletion, made a diagnosis of IL-10R, and then the father was matched for the stem cell. And we did the HSCT at 11 months of age. Its child is on follow-up at 30 months of age. And this child, we published the case even during pandemic. Somehow we saw to that things were being done, and we wrote this up, and we published this case. This is the child with rectovaginal fistula. First, we had to do diversion colostomy, then surgery for that fistula was done, then the HSCT was done. And it was a good story. Parents were happy. And now at 30 months, we see this child sitting up like this and reading a book. It is nice for the parents, but there are other issues now, and they are coming regularly for follow-up, which probably we can discuss later. And as this case, an IL-10RA mutation case came, and this sibling death due to similar illness, we found this out. Then the father donated, and this child is also doing very well. So what do we learn? Clinical features of IL-10R mutation. When will you pick up? Especially when you have perianal fistula, less than 3 months of age, colitis, arthritis, you can straight away do the clinical exome sequencing. And what is this IL-10R mutation? Only this I will be explaining to you, because IL-10 is an important anti-inflammatory cytokine. So what does it do? It prevents this TNF alpha being released. So it inhibits the release of TNF alpha. So when you have mutations in either IL-10RA or IL-10RB, you get 100% penetrance and you get the disease. And the percentage is high in Asia, 5 to 38%. All the papers you will see are from China, are from Taiwan. That is, and we also seem to have papers, whereas from the West, the paper which I showed you, 1,005 cases, IL-10RA and IL-10RB are not seen. I'm sure Geeta would have seen a case, Srini and I have seen, and I'll be showing you the cases which we saw. So together we are seeing cases and we are referring all of them for the transplant. So this is the defect in IL-10 signaling is one thing which we should remember. Of the 6 pathogenesis, this is very important. Recently, we also had a hyper IgM syndrome, child recurrent aphthous ulcers, because the child was less than 4 years, very early onset IBD. That point, do the immunoglobulin profile before even going for colonoscopy, before endoscopy, because after doing colonoscopy, if you get a finding and then you will start treating them as the classical IBD, then they will not respond, and then you will tell the parent, oh, it may be something. Instead of that, now the proportion of monogenic IBD is going to be higher. So the pediatricians themselves, when they refer, they can do the immunoglobulin profile and you get the T cell subset. I think someone asked me also, Madam, why did you do immunoglobulin profile in this child? You're not getting much of the history. It was just recurrent aphthous ulcers. How many times I've got aphthous ulcers? Why did you do immunoglobulin profile in this child? This child came to me because of loose stools. They wanted a procedure. So I said, I will do this. And it was, we have picked up IgM, hyper IgM syndrome. So what will I do? But when I did the colonoscopy, I did see ulcerations on the IC valve. I did see ulcers in the colon. But the mutation came as CD40LG, and the child will be going for HSCT to next month, June. It's going. Because for this child, it's no use giving steroids or azathioprine. You'll only make it worse. So very, very important to identify this group of monogenic IBD in this group. So when will I suspect? So what is monogenic IBD? Their presentation of monogenic IBD. When will you suspect? When you see a child with loose motions, but in addition has some folliculitis, just like, as pediatricians very easily will pick it up. We'll say, oh, there's some immune deficiency. Look at this child, hypoalbuminemia, perianal involvement. That is a clue saying that this is a monogenic IBD. And this is a very good mnemonic, was published by Ulick in 2014, republished in 2021. And they are very clear. The mnemonic is young age matters most. That is, younger the child, think of monogenic IBD. This is the most strongest predictor for risk of monogenic IBD. I think this we have to be very strong. Infantile onset IBD. Second is history of consanguinity, sibling suspected with MD. In our history also, we found many children earlier, first sibling died, then only the hit. We said, see, you spend so much of money, just spend the 17,000 more. We'll make a diagnosis and then we'll go forward. Actually, we push them to that nowadays. We tell them, no, do this. Instead of getting repeatedly admitted, not doing what it is, please do this test, and then we're asking them to do. Then failure to thrive. Treatment with conventional medication fails. Recurrent infections, all this we all know. Severe perianal disease. And then if you have recurrent intestinal atresia, surgery, skin lesions, dental hair abnormalities, these are clues when you think of monogenic IBD. So you will do this. So the first 2 stars, as I told you, these are the 2 most important. Young age, family member, consanguinity, and then you have these comorbidities, extraintestinal manifestations. And why should we do it? Why should we analyze monogenic IBD? Because that needs a complete, more exhaustive workup. It's not sufficient to do CBC, CRP, endoscopy, colonoscopy, small bowel. You need more. I will tell you what all you will need. And you have to anticipate, identify specific complications. It helps in genetic complications. And they need non-standard therapies. You can't go and give them steroids. You cannot give them biologicals. They need HSCT. They need other therapies, which I will show you. And unnecessarily, you will not be doing surgery and giving medicines which may not benefit them at all. So in the diagnosis of very early onset IBD, It's the same. You must do as for classical. You must take a good history. You must do the basic investigation. You must do endoscopy. You must do histology, as I was telling you, to find out the effect of the disease. You'll see the hemoglobin low, the albumin low, indicators of mucosal inflammation. You must look for inflammatory markers. But when the infant is less than 2 years of age, or when the infant is just divide them into two groups, when there is a suspicion, apart, as I told you, exclude infections, exclude allergies, but most important, bring this higher on the list. Immunoglobulin profile, lymphocyte subset, try to bring it higher because you will pick up CVID, you will pick up hyper IgM, you will pick up agomaglobulinemia, you will pick up SCID. Recently, also a 7-month-old baby, SCID missed, because it depends upon who the child goes first. If it goes to a hematologist, they will do. But suppose pediatrician, we'll always say a child in India can get 4 to 5 infections in a year. This is a common teaching for us. So we also tell the mother, don't worry, 4 to 5 can come. But the something more, that intuition, there's something more in this child. And then if you do, especially as I told you, the younger and sibling death, consanguinity, please look further, especially when there is some blood and mucus in the stools in a child who is exclusively breast milk. Do this. Then if you can do functional studies, yes, but in our thing, actually, I think Srinivas, Geeta, all of us will agree, Prashant, that we jump straight away into the exome studies and we get the diagnosis. Histopathology, are there any pointers to say it's monogenic IBD? Actually, nothing, because we don't see much of granuloma. We see more of apoptosis. If the histopathologist, when you see a child of colonoscopy, you pick up and you say there's apoptosis, madam, or something, they tell you, you must go see, have I done the immunoglobulin profile? This looks like a primary immunodeficiency. Or if you see too much of villus blunting and lymphocytic, like villus atrophy and eosinophilic infiltrates, these are the features which are associated with monogenic IBD. So genetic testing, which to choose as pediatricians, you like to know what should I choose? See, we all know most of the diseases are on that exon. Exon constitutes only 1% of the genome, but still 85% of the known diseases causing mutations are located on exons. So it is enough if we do the whole exome or the clinical exome sequencing first. Write all the features and do the CS. If it does not come into this, then you can go for genome sequencing, which will be more costly. Clinical exome sequencing will pick up most of the mutations, and they have a panel for very early onset IBD. You can pick it up. So who will you refer for genome testing? As I told you, extreme severe phenotype, early urge of onset, recurrent infections, not responding. And management of very early onset IBD, as you all know, it's a team. The most important is the pediatrician. Without pediatrician, no IBD, no PIBD, no very early onset IBD. They are the ones who are going to refer. Pediatric gastroenterologist, radiologist, pathologist, nutritionist, psychologist, surgeon. Madam, you've left off someone. Now, after all this teaching, I should not forget hemato-oncologist, genetist, and immunologist. So all of them are important for management of VREO thing. The classical, this is the one we all talk about, steroids, 5-ASA. We have the exclusive enteral nutrition. We have the biologicals, which Dr. Srinivas will be talking about, surgery. And this is the usual. For induction, we use steroids. Then for biologicals, we use for induction. But maintenance, we use as a thioprin. But look at the therapy for the non-classical very early onset IBD, completely different. HSCT, hematopoietic stem cell transplant, becomes that. Definitive, you can do it only for IL-10R, IL-10. That's why we did for our children. For SCID, yes, we are doing. For CGD, we've done. CD40, I was telling you about hyper IgM syndrome, you can do. Care, overall good outcome only with this. This is the treatment of choice. Probable role of BMT or HSCT, maybe for LRBA. I think Srinivas has one case of that, CTL4. Variable, we get it in STAT1 or XIP, not much. Not indicated, very, very important, especially for that case which I showed you first. Epithelial barrier defects, don't go and do HSCT. Actually, may do more harm than good. Other targeted therapies are there, like IL-10-1 target for this mevalonate kinase deficiency. You can use this one, ruxolitinib, or you give abatacept. All this specifically, some new ones have come, IFN, interferon gamma for CGD. So the therapy is completely different from what we teach in pediatric IBD. So in conclusions, my friends, I'm not able to see you, no eye contact, but I'm sure I have shared much about very early onset IBD. I've made it more simple because now I am understanding it better. For me also, very early onset IBD, monogenic IBD was all some confusion. Now it's a little clear. Very early onset IBD, less than 6 years of age. Under that, you have 20% to 25% of a monogenic IBD. The rest are all polygenic. The polygenic may have the classical present. This monogenic only we have to identify because the treatment is different. So it is a unique subset of a complex group of children, phenotypically and genotypically different from the older onset PIBD. Because after the age of 7 years of age of onset of PIBD, monogenic IBD becomes negligible, and it comprises both classical and a small group. Investigate as for PIBD. Recognition of monogenic IBD is essential. Targeted therapy and personalized precise medicine recommended. Thank you for your patient listening.
Thank you, Dr. Maladi, for that brilliant disposition of the topic. And it's really an eye-opener to the pediatricians, general pediatricians like us, because as you said, generally we think it's not that common. IBD as such is not common in pediatrics, and only less than number occurs in less than 6 years. But now again, we have subdivided into infantile, that is less than 2 years, which has got more of a ulcerative colitis like presentation, so that as you had correctly mentioned, we may tend to brush aside as the means persistent infection. So as you have mentioned, I think your anti-R index of suspicion should be high, especially when the child is young and presents of associated with failure to thrive or the family history, and also that we should also think of the possibility and refer to you on time. And as you said, I think we have to think of other investigations like immunoglobulin assay or T-cell subsite analysis, and even there is a role for genetic studies, or there's a main role is for genetic studies. So I think really thank you for sharing the cases, that interesting cases, that is 9-month and even as early as 2-month-old babies.
It's an eye-opener for us. We are learning more every day. Yeah. We knew nothing in 2000. Now we know something. We don't know everything. Yeah. I don't know when we will know everything. I think Srinivas will agree to that. From nothing, we've come to something. We are not in everything, but at least there's some understanding we've got. Otherwise, we also used to bring what to do. If I can refer it to someone, I can refer who to refer. Maximum, I can refer to Srinivas. That's all. Can't refer to anyone also. But now when we understand, parents are also able to understand. If we can tell them, see, this is a genetic problem. Otherwise we also wonder how to treat. So now we know this is a different group, That is why we were getting confused with that group. We went and gave all biologicals to a perineal fistula, which probably the child had IL-10R. And I was doing a blunder because I didn't know. So now when they are younger, 17,000 you spend for the genetic studies and tell them, see, this is a different disease. Yes. I think there are some questions.
Yeah, this is the first question that is from Dr. Geeta again. How do you monitor for this during follow-up?
Yeah, see, now the monitoring is also like management. The monitoring is also done by hemato-oncologists and ourselves. Now this child who had this HSCT, they come to us for the loose motion now and then. But their follow-up of their counts, everything is being done by the hemato-oncologist. This first child, the counts are decreasing. So they are taking blood now and then every 3 months from the father and giving. Actually is going for the second HSCT because it's not able to maintain the count. The other child is doing well. One more child with Srini's thing is doing much well. So it all depends upon the type of mutation. But IL-10R, IL-10, if you do it early, they are doing well. So it again comes as a team approach. We are not giving any steroids or anything. Those ulcers, when the count decreases, Geeta, the ulcers start increasing. Actually, this child starts passing blood and mucus again. So that is how the mother also is able to tell. At that time, I just tell them, okay, if you want to give, because the studies from China also, they just give mesalamine they used to give now and then. They used to give in between a little bit of steroid. Somehow they were managing. But if they once they gave HSCT and the child picked up, then they didn't require. So now this child, the other child is not requiring anything. It's just requiring supportive treatment, nutrition. First year, we are only giving them extensively hydrolyzed formula thing. Though it is not CMPA, we feel that the gut cannot absorb that. So we are giving only hypoallergenic formula, Geeta.
Can the biologics be used? I think that is the next topic.
Yeah, that's the next topic. For these children, I think he will cover monogenic disorder. Once you diagnose, we should not waste our money giving biologics, except the other few biologicals which I had showed you, not the regular ADA, not infliximab, none of them will work. Because, though we teach perianal fistula, rectovaginal fistula, only biologicals work. But if you know this, less than 3 months of age, this baby is presenting differently, then you will not be giving that.
Another question is post stem cell transplantation, can you revert back to the normal diet?
Yeah, that child is now eating rice. After the age of 1 year, they are taking regular food. The child has gained weight. You saw the child sitting and reading the newspaper. All that is doing, it's running and all that. Much, much better. The parents are very happy because they thought they would lose that child. So the child is doing very well under the care of both of us, keeps in touch with us, got its vaccines, done everything, and is doing well.
There will be some difficulty if the child develops a graft versus host.
Yeah, very, very difficult. I think it's the most difficult when they call us after this GVHD. But the hemato-oncologist, they do a good job. I get so scared for the amount they push. They just push the steroid up, bring it up, and then, they give the medicines and they go. They're used to it. Madam, this will come, madam. It will take time, madam. And during the time, what I do, I just bring down all the formula to a hypoallergenic formula, support them. And yes, there are ulcers, but they do a good job. They just push up the steroids, which as such we will not do. They nicely push it up and they know it will come. Sometimes they say, this is good, ma'am, this is good, and then they pick it up. So they're used to it. So HSCT, like you said, GVHD, we should be aware of that. And GVHD of the colon, I think, is one of the bad things we get. And we are now seeing more because I think now we get attached to these people who are doing transplant.
I think there are no more questions. Thank you, Dr. Maladi, once again for the excellent session. It is really
Thank you so much, Dr. Lalita. It's a pleasure to be having you as my coach. And always you're there for me. Thank you. Thank you.
Thank you. Thank you, Prashant.
Thank you, madam. I think we don't have any more questions, I think, in the chat box. Madam has given a nice exposition of the topic, and there were significant interactions also. I think I thank Malati madam as well as the chairperson, Lalita madam. I think now we will move on to the next session. The next topic is biologicals in pediatric IBD, step up or step down. I invite Geeta madam to introduce the topic and the speaker. Over to Geeta madam.
Thank you, Dr. Prashant. Good evening, IIP Trivandrum, and thank you for giving me this pleasant job of introducing Dr. Srinivasan. Dr. Srinivasan Shankar Narayanan is a close friend, and I've known him for many, many years, I think since we were doing PG. I'll give a very short biography. He's got a very long CV. He has done his pediatrics from Calcutta Medical College, and that is the connection with Kerala. Also, his wife is from Kerala. He did his DCH from Calcutta Medical College and subsequently his MNAMS and DNB. And he did his pediatric gastroenterology fellowship in SGPJ Chandigarh. Subsequently, he had done another fellowship in Australia, where I think he did a study also on IBD. So he's an excellent speaker, a very great teacher. He knows how to simplify things very well. He's got a lot of publications and a lot of work done in IBD, especially in very early onset IBD. And he would be the best person to talk to us on biologicals, step down or step up, what is required. Over to you, Dr. Srinivasan. We're looking forward to an excellent talk. Thank you.
Thank you so much, Dr. Geeta. I hope I will live up to the expectations of what I've been told. of an excellent speaker. I'm overwhelmed by the first speaker. Okay. When Prashant first introduced this topic to me, the first question I asked was, who am I talking to? And he said that this is all to pediatricians in Kerala. So I said like, hey, you're giving me a very, very difficult topic to be simplified to somebody who doesn't know the length and breadth of IBD. How do you expect me to talk to them on step up or step down? This is a very important topic to be discussed with pediatric gastros. Prashant has assured me that all the pediatricians in Kerala are well versed in the basics of IBD. And I still find it difficult to simplify this topic, but I assure you I'll try my best. To know what is biologicals in IBD and to know whether it's top down or step up, we all realize that inflammatory bowel disease, as MBBS students, we were taught are of two types, ulcerative colitis and Crohn's. As we became pediatric gastroenterologists, we understood that inflammatory bowel disease is a continuing spectrum. On one end is Crohn's, on the other end is ulcerative colitis. And in between, there is a small spectrum called indeterminate colitis or IBDU or IBD of unknown etiology. We all realized that the pathophysiology of IBD involves the interplay of quite a few things. On one side, the microbiota. Two, the way the host responds to the antigens generated by the microbiota. Three, environmental triggers, including smoking and a Western diet. And four, genetic susceptibility, which will determine, despite all of this, whether you will get IBD or not. And it is very interesting that the immune responses in the gut, which are generated by the IBD, are not similar for the same disease. Sometimes you have Th1 predominant response, sometimes you have Th2 predominant response, sometimes you have a Th17 predominant response. Oops. So if there is somebody who's interested in making a career and if they are young in their career, please consider immunology, because even GI people and IBD people need to learn about GI immunology. But cutting the very difficult topic to a simplified version, we all realize that the T regulator cells are the drivers of inflammation, and you may have either a Th1, Th2, or a Th17 response. So, depending upon what form of an immune response you generate, we need to target and give therapy which can be specific to control your disease rather than generalized. So what are the drugs that we use for the medical management of IBD? We've known about aminosalicylates, we've known about steroids. We have slowly started using immunosuppressive agents after a long hiatus, and now we use them very, very frequently for everybody. We have antibiotics which are being used in perianal Crohn's. There is a form of therapy which is very popular in Europe called exclusive enteral nutrition. Then we are going to talk about biological agents. Now there are even smaller molecules called as the Janus kinase inhibitors. And then there are other forms of therapy called fecal microbiota transplant and even worm therapy. So how is one chosen over the other? We have to pay attention to the disease severity and the clinical phenotype before deciding what is ideal. We go by literature and scientific evidence. So if somebody tells us that a fistulizing or a penetrating variety of Crohn's will respond best to biologicals, then we choose that. We choose efficacy of the drug. We also look at side effect profile. So if we find that the side effect profile of steroids is very high, we no longer use number of steroids in our management. Cost and insurance coverage becomes an issue in India. Availability of agents is also an important factor. Finally, talking to the patient and how the patient perceives a form of therapy, patient acceptance, and also experience of the treating physician is important when you choose one over the other. That is the reason why some centers may choose a form of therapy more often than the other. When we look at the therapeutic pyramid in IBD, This is a very old pyramid. This is not the current pyramid. But generally, a therapeutic pyramid involves immunosuppressive protocols in a step-up approach. So as you go up the ladder, we go on to more possibly potent agents, but with more potent or more effective agents comes the risk of certain side effects. So people are afraid to go on to more potent therapy. And that is one of the reasons why people delay in stepping up. So that is the psyche of the person who treats. What if my child developed TB? So why go on to such immunosuppressive therapy? So that is something that looms large in the head of people. Earlier, step-up therapy, people never even stepped up to azathioprine and 6-MP. But nowadays, when we talk about step-up therapy in IBD, we are essentially asking the question, are you on to biologics or are you not on to biologics? How early are you going to institute biologics? Are you going to start with biologics and come down, or are you going to do what we call as a quick step up or an accelerated step up? So for this, we should understand that childhood IBD is very different from adult IBD. So children are not small adults. When we counsel the entire family. The disease is known to be more aggressive in children. Therefore, the treatment needs to be more aggressive. The second concept is growth and puberty need special attention. Because if you lose the window of opportunity, IBD can lead to stunting of growth, delayed puberty. So children will remain stunted even if your IBD remains treated. So we need to ensure their growth during a adolescent phase or during their pubertal sport. So the IBD needs to be controlled in order to adrenarche and puberty to take off. That's very important. So this is how is IBD in children more aggressive? Like Dr. Malathi had earlier mentioned, pancolitis is more common in children. And if you look at how they progress, they give a much shorter time from the time of diagnosis to actual colectomy if you don't treat them well. Similarly, in Crohn's disease, it's more a diffuse disease involving the entire colon rather than a localized ileocecal Crohn's that you see in adults. And it is well known that disease progression can occur in the first decade after the diagnosis in children, when we do not resort to a very good effective biologic therapy. So this is a beautiful slide that is usually given to us in all the lectures in pediatric gastroenterology. So if you look at the above slide, on the top half, you find that if IBD is treated very mildly also, over a period of years, say 15 years from the time of diagnosis, the major component of IBD in adults is the inflammatory component. A very small component of the IBD becomes a stricturing or a penetrating variety of IBD. Whereas in children, you see a contrast when you look at the bottom half of the diagram. In pediatric onset Crohn's disease, you find within a couple of years, the inflammatory component have all become stricturing or penetrating. And once you go into what we call as a stricturing or penetrating variety, complications are more, need for surgery is more, and they will not respond to standard therapy. Quality of life becomes very poor, nutrition goes down, spiraling down. So it's very important to focus on the window of opportunity that we get, pick them up in the inflammatory part of their disease and treat them effectively, not allowing them to go into complications like stricturing or penetrating disease. So now, what does step up or step down mean? Step up in today's world means stepping up using biological agents, and top down means starting with the biologicals, early aggressive therapy, and then coming down. So when you talk about protocols in top-down approach, there are no clear defined protocols. So it's not like you just give some 3 doses of infliximab and then you come down. Sometimes once you are on to biologicals, you are on it for about a year or 2. And then if the clinician decides that you are on significant remission, then a decision is taken to step down from the biologicals and put them only on immunosuppressants like thiopurines and keep monitoring them. So you do not know from the start whether everybody you will be able to step down. Similarly, you will not know from the start whether everybody requires such a high, costly or a potent agent in order to get control of the disease right from start. The cost also plays an issue when we decide on step up versus step down. Most of my colleagues and pediatric gastroenterologists in India, I think except from a few specific situations, will agree that they would prefer an accelerated step up, which means you begin standard therapy, but decide very quickly that this is not working, and you go on to biologicals very quickly. So you do not shy away from biologicals when it is needed. The decision to go on to biologicals needs to be taken fairly quickly so that you still catch them in the inflammatory stage. Finally, whether it is step up or step down, it doesn't matter. What are the goals of therapy? To achieve clinical remission, to ensure appropriate growth and good quality of life. The goals have slightly altered. No longer are we targeting clinical remission, which means clinically you are well, you are not happy. We want to also achieve very good control of the disease, which means mucosal remission. We also want to minimize the side effects, and we want to maintain this state of IBD for a sustained period of time and deep remission for several years. Those are the goals of therapy. So our treatment goals have changed. We have raised the bar. So world over, sometimes people put them on some forms of therapy and repeat scopy to ensure that there is a deep or a mucosal remission. So when we are targeting a higher standard of care, we need more effective drugs. These are the arguments for using biologicals in children. What are these biologics that we are talking about? Biological drugs are not chemicals. These are basically substances made from a living organism or its products. So they are used in the prevention, diagnosis, and treatment of cancer, and a broad definition of biologics should include antibodies, interleukins, and even vaccines. So most of the biologics that we use in IBD are antibodies. They are all usually some form of antibodies. So the biologics that we use in IBD target specific receptors or soluble molecules to suppress the specific pro-inflammatory pathways. Some of you might remember the earlier diagram I showed you when I talked about how immunology is a very important field in the future. So steroids are generalized immunosuppressants. So they target the entire body, but the action of biologics is highly specific to the gut. So with this, these agents also have higher rates of mucosal healing, but without the side effects of the steroids, like Cushingoid syndrome, growth retardation, osteoporosis, cataract, emotional changes, etc. So this is the importance of using biologics in IBD. When we talk about biological therapy, we initially thought we had only infliximab and then adalimumab. But now you find there are so many mobs that we need to become aware of. So there are 4 anti-TNF agents, 2 anti-integrins, and 2 anti-interleukins, 1 anti-interleukin as well. All of these are coming in. And if you thought that these are all in the pipeline, you will be surprised that many of these have undergone rigorous studies. So infliximab has now been studied for more than 20 years. There have been several clinical trials for each of these biologics. Biologics are here to stay in the treatment of IBD. And this is just a representation of how many other biologicals and smaller molecules are waiting in the pipeline and research to explore into treatment of inflammatory bowel disease. So what do we need to know while using biologics? In any tertiary care hospital, we want the infectious diseases team to clear these children before we begin biologics. What are we worried about in India? We are worried about indolent TB. We want to vaccinate them so that they don't get any serious chickenpox or any other infection while they are on biologics. So we need time. Once you have given live vaccines, you can begin biologics only after a couple of weeks. And on biologic therapy, please avoid live vaccines. Biologic therapy, nowadays, the standard of care is such that all children on biologics, we measure trough levels to ensure that they are adequate. Sometimes, if you find a lack of response, we also need to check and measure for antibodies that may develop to these drugs. And we also have to continue to monitor them for the risk of infections. What are the possible adverse effects that we are worried about in anti-TNF therapy? There can be infusion-related reactions. There can be reactivation of an indolent TB or even hepatitis B. Some of them can develop psoriasis and lupus-like syndrome. You can develop any serious infection. What they dread in the West is a form of lymphoma called hepatosplenic T-cell lymphoma, which seems to be common in boys. Very, very rarely, you can have a demyelinating disorder or sometimes some amount of liver toxicity. Let us see how we use biologics in our clinical practice. So this is a typical scenario where we have a child where we are confused whether it is ileocecal Cox or Crohn's disease. So this is an 8-year-old who came with a history of fever for 1 year and a significant weight loss of 8 kg. She's lost her appetite. She's got right lower quadrant pain and lip ulcers and angular cheilitis. She doesn't have diarrhea, but she has hard stools. 7 months ago, she had a wound in the perianal region with a purulent discharge, but it healed. No family history of IBD, no history of contact with Cox. She was initially given antibiotics, treated for the fever and worked up, and an ultrasonogram showed a thickening of the ileocecal region, and a barium enema showed again filling defects with strictures in the ileocecal junction. The upper GI scopy was normal, but wherever she underwent, the colonoscopy could not be completed. So possibly sometimes adults do the scopies and there is a tendency for them to not do multiple segment biopsies. She was started on empirical ATT and she had a very good response, weight gain of almost 3 kg. But about 3 months later, again, she starts off with fever and pain abdomen. And when she came, she was poorly nourished, both weight and height, less than 3rd centile and 3rd to 10th centile. And these are her labs, which clearly indicate that there is some form of an inflammation going on, as indicated by the high ESR, CRP, and platelet counts. There is a slightly lowish albumin level. She was worked up for, again, a resistant form of tuberculosis, but her workup was negative. She was worked up for immune deficiencies and it was negative. And these are her scopy, which shows the ulcers in the ileocecal junction, but rest of the colon is completely normal. So this is disease which is restricted to the ileocecal junction. But we have to send biopsies from every place. Now, though we sent every place multiple segment biopsies, we could not hit upon a granuloma. The tissue for TB PCR was negative and the tissues were sent for Mycobacterium TB culture. And all the other biopsies came back as normal. So we think that yes, this is unlikely to be Crohn's. This is more likely to be a tuberculosis of some form which is not responding to standard therapy. This ultrasonogram, which was done in between, suddenly said that the lack of significant adenopathy makes a TB less likely. And maybe this child could have actually inflammatory bowel disease. But what was more alarming was they spotted a saccular aneurysm arising from the posterior wall of the right common iliac artery. And we were worried that this aneurysm may burst. we did an MR enterography and MRI pelvis, which spotted, apart from the ileocecal problem, and also an interanal sphincteric fistula. So there was a risk of rupture from this very big aneurysm. So now, are we dealing with Crohn's or abdominal TB? The initial response to ATT, isolated IC involvement may make you think it is abdominal TB. But the oral ulcers, the perianal sphincter fistula, and no history of contact, raised inflammatory markers, and the recurrence of symptoms make us think this is Crohn's, isn't it? So in discussion with the family, we felt the Crohn's was more possible than TB, but we first need to tackle the aneurysm, but she didn't have money. So a lot of things went into it. Social worker involved, institution offered discounts, there was some crowdfunding done, and she was continued on ATT. And when followed up, we found that the aneurysm had grown bigger. And 4 to 6 weeks later, the culture was also negative. The oral ulcers had worsened on the ATT. And finally, a lip biopsy done for an ulcer revealed a small granuloma. And then we convinced ourselves that this is indeed Crohn's disease. We started this child on methylprednisolone, but had an accelerated step up to infliximab because her inflammation did not subside with simple steroids. She underwent a coil embolization for her large aneurysm. She was continued on anti-TNF therapy infliximab for almost 1 year, after which she has been stepped down to simple thiopurines. So what does this tell us? That there have been several attempts to differentiate TB and Crohn's, but finally, in a diagnostic dilemma, a trial of ATT is justified. But more importantly, when the first evaluation is done, I think we need to send multiple segment biopsies from the upper GI and colon, including the ileum. And ileal biopsy should be sent for looking for the TB in the pathology, as well as gene expert, as well as culture. Aneurysm can be a very rare extragut manifestation of Crohn's disease, and anti-TNF agents are very potent agents that help control aggressive IBD. So now we talked about how IBD, this is very important because if you gave steroid or immunosuppressant to a child with TB, then what happens? The TB will just get disseminated. So this is the risk, and this is a permanent problem we have in trying to differentiate TB and IBD. Okay, the second case scenario talks about a very valid question. Once on to biologics, how long? And I'm taking the opportunity to introduce this concept called exclusive enteral nutrition. A 12-year-old boy was diagnosed by me in 2010 with Crohn's disease. He had a significant amount of small bowel involvement on the CECT apart from upper GI as well as colonic involvement. He initially improved on steroid and he achieved remission and went on to thiopurines, which is azathioprine. So this is classical step-up therapy. But he had multiple relapses over the next 3 years. How did we treat each relapse? So initially, we started him on steroid. So how many doses of steroid do you give? So we can't keep giving him steroid. So I convinced the family to go on to long-term biologics. And they did very well. I initially told them that, yes, let us give him a year of biologics. And it was year 2012, 10 years ago. The family agreed, went on for a year of biologics, but then found that they couldn't afford to continue biologics forever, and we didn't offer them a cure. So when he came back with a relapse after stopping biologics after 1 year, what we offered them was exclusive enteral nutrition. This poor kid went on for at least about 3 or 4 courses of exclusive enteral nutrition, and each time he would come back with beautiful clinical remission, weight gain, and a PCDA score of 2.5. But again, this does not offer a sustained remission. Finally, he did go on to biologics. And because these biologics were given in a staggered manner and not continuous basis, eventually he landed up with a stricture. He underwent even a surgery. He continued to have inflammation in other parts of the small intestine and continues to take biologics. So this is living with Crohn's disease, and sometimes some Crohn's is very aggressive. You probably require biologics. It's difficult to find out who we can stop and who will continue to need biologics. So what is EEN? EEN is basically a complete liquid diet which consists of a polymeric formula which is given for about 8 weeks. However old you are in pediatric, though you can eat, bite, and chew, this is a form of therapy where you're supposed to only keep drinking a polymeric formula. You're not allowed to eat anything else except some water or some juice. And if you do not tolerate this form of therapy, because usually sometimes some special formulas are used for EN, we will give nasogastric feeds. This form of therapy is extremely popular in Europe because they find that nutrition, you are obviating the side effects that come with steroids. So the first form of therapy in Crohn's in Europe would be nutritional therapy. So how this works, nobody knows, but they believe that by giving this, it changes the probiotic gut microflora and reduces the pro-inflammatory cytokines. But there is very poor acceptability of EN. So only 4% of gastros in North America are using EN as compared to 62% of European gastros. So I think the factors why EN is more used and not so used depends upon where you are trained, your familiarity with using EN, whether you have the availability and support of dietitians, and it will be much more costlier than using steroids, and also how the patient perceives it. So patient compliance is likely to be poor. So sometimes that also we have to know how EN works. Having said this, I have had one adolescent who has completely attained a mucosal remission with EN and is now doing well only on thiopurines. Now let's look at a scenario where we are stepping up therapy in Crohn's to avoid the steroid side effects. So this is a child with Crohn's disease, initially started on steroid and azathioprine. Then all our patients are non-compliant, lost medical follow-up, took native medications and came back with severe abdomen pain. A pad endoscopy again reconfirmed diagnosis of Crohn's disease, and now the MRE showed IBD involving also the small bowel, the jejunum. He was restarted on steroids and azathioprine, but the issues we had to tackle was he was obese, he was overweight and had acanthosis nigricans and dyslipidemia even before starting the steroid. So on steroid therapy, he developed hyperglycemia and diabetes requiring insulin therapy. He developed also hypothyroidism and acne. So all the complications and side effects effectively dealt with, and steroids successfully tapered off and put on azathioprine. And then he was off insulin subsequently and put on oral hypoglycemic agents and did well for 2 years. But during this adolescent growth spurt, when he was only on simple azathioprine, he had a recurrence of disease. And MRI again showed involvement of the jejunum and sigmoid. Maybe because the azathioprine dosage was not increased proportionate to his weight. Or maybe there are some factors we feel that hormones can influence the relapse of Crohn's disease. He was a candidate who did not want to go back to steroid and experience the same side effects. So yes, we put him on anti-TNF agents, biologicals. Because he was so overweight and his body surface area was almost 2.14, we started him on 160/80 induction dose. For about a year, he remained on 80, then followed by 40. 2 years later, his MRE was completely normal. PCDA score was 0. He is off adalimumab and only on azathioprine. So here is a success story where you are able to withdraw also biologicals. He also simultaneously started exercising and becoming weight conscious. So he's not on any medicines for either his diabetes or dyslipidemia. He continues to remain on thyroid supplements. And this is him. And we are very happy that biologicals improved his quality of life. You can see how he was earlier, overweight, and now how he is trim and slim. Do we ever encounter infections with biologics? This is a case scenario. So let's look at a 10-year-old girl who was diagnosed with IBD and pancolitis. She had transmural involvement she was suggestive of ulcerative colitis. But this was a severe form of ulcerative colitis, and that is why there was transmural involvement. Long-standing ulcerative colitis. There were no strictures and there was no upper GI involvement. Biopsies were consistent with UC, but she was poorly treated. She was initially started on steroids, ASA, and iron supplements. Did that help? When the treatment was commenced, this is how she was. But then 1 month later, how is she?
You can hear it there, here, and in the room.
She continues to have anemia, high counts, ESR, and hypoalbuminemia worsening while on the steroid. So obviously, whatever we are doing, we are not doing right. So we have to do something different. This decision should not be taken several months later, but quickly. And this is so we decided to step up to adalimumab. We gave her 1 dose of adalimumab after the X-ray, TB gold, everything, etc. Within a couple of days, she developed a spontaneous pneumothorax and came back with a mild right upper lobe pneumonia. She was shifted to PICU, required ICD, recovered with antibiotics. Her IBD recovered, no doubts. Then she was put only on ASA for a very long time, not even azathioprine. Subsequently started on azathioprine and remained well for 2 years. Then the parents thought she was so well, let us stop the medicine completely. We stopped the medicine, and after a couple of months, the parents were thinking, why is she not gaining weight? And they did a fecal calprotectin. And again, you find that the calprotectin was 2000, and she started developing symptoms. She was restarted on therapy and doing well now only on aminosalicylates and thiopurine maintenance therapy. So yes, with immunosuppression, we do see some serious infections. We have even lost 1 child due to a disseminated tuberculosis. We have had children who have developed disseminated tuberculosis and also successfully treated them after stopping these biologics. So, but that should not deter us from using biologics when it is really required. And this case will tell you why we should use them. An 11-year-old girl with ulcerative colitis came for a second opinion. Look at her story. She's already started having extra gut symptoms with oligoarthritis. And then 3 years down the line, bloody diarrhea, abdomen pain, anemia requiring a PRBC, and colonoscopy, pancolitis with biopsy suggesting ulcerative colitis. Standard therapy with aminosalicylates, steroids, and azathioprine, she was being treated. And on the treatment, she was continuing to have little amounts of blood in stool. And she had lost almost 7 kgs in the last 9 months. Her ESR is 40, calprotectin is only 115. So sometimes it misleads us, and low albumin levels. But look at her growth. Are we doing well? So here, a little amount of bloody diarrhea, not causing anemia. If you look at only her labs, you will be misled. You're thinking she's okay. ESR is 40, calprotectin is only 115, albumin is 3.1, let her eat better. But look at her growth. Here, what is important in pediatrics is growth. So this is an indicator that you have to step up therapy. When we did a scopy to know whether she's achieved mucosal remission, you are surprised. This child with a hemoglobin of 12.6 is having this on her endoscopy. Such a bad colon. But still she's able to maintain a 12.6 hemoglobin. So after doing all workup to rule out any indolent infections, an ID and rheumatology opinion, she was commenced on adalimumab. And what a change it made to her quality of life. She initially went on 80 mg for about 6 months and then 40 mg for the next 6 months. And we continued to monitor care through the lockdown using online consultation platforms with a very small dose of azathioprine. So you can see the response serially over the period. This is during the lockdown. Her hemoglobin pushed up to 14.6 and the ESR dropped to 10. Albumin improved to 4 and platelets dropped down to 2.99. So her inflammation is well under control. And on adalimumab, what a difference to the scopy. This is mucosal remission. This is what we want, and this is what we want to offer as a standard of care to all our patients. Biologics have changed her life. From the 22 kg, she became the 43 kg and she gained 20 centimeters. Wow. These are wonder drugs. So the take-home messages I wish to share is, IBD is obviously an inappropriate inflammatory response to intestinal microbes in a genetically susceptible host. Aminosalicylates are useful only in the mild to moderate ulcerative colitis. Don't keep on sticking to them for a long time. Exclusive enteral nutrition, again, is a novel therapy which may be used in milder forms of Crohn's disease. Corticosteroids are useful to control the flares, but you cannot use them for long-term maintenance. Immunomodulators, thiopurines, are the ones that we rely on for maintaining remission in moderate to severe disease. So we have to rely on thiopurines for maintaining the remission in all our IBDs. The treatment goals have now changed. We target mucosal remission. And for that, we need potent agents which are very specific in their action, producing high rates of mucosal remission. And these should be combined with immunomodulators, because there is very good evidence to say that in moderate to severe disease, we are able to achieve mucosal healing and decrease disease complications and need for surgery when we combine the biologics with immunomodulators. So you have seen so many cases now. Step up or top down. I think we have changed. Top down is very ideal if you spot a very aggressive phenotype of the disease, like a fistulizing or a penetrating disease. Top down, I tend to use, especially if you have a lot of perianal disease. But in most other situations, it is not gradual step up, but an accelerated step up. Important take home is, do not delay the use of biologicals where necessary, as we are dealing with pediatric IBD, and we need to ensure their proper growth. IBD is unpredictable. It's very heterogeneous. So the disease severity and outcomes are highly variable. So you do not know who will respond to even biologics and who will not respond to biologics. We have a child even who's not responding to biologics, and we want to change biologics, and we found even antibodies. So be it top down or step up, one size fits all standardized treatment may not work. We are slowly moving towards talking about personalized medicine, where we want to know who will respond. How do we know? Currently, we are using certain clinical phenotypes based on our scientific evidence and saying, hey, stricturizing disease, you have to put biologics. Hey, very simple mucosal ulcers, I think they will do well. Isolated small bowel disease, maybe they will do well on exclusive enteral nutrition. These are the forms that we are being telling, but these are all very poor indicators. So what we need is genome-wide association studies to tell us and give us molecular stratification to tell us what drug to use, where to hit, and each person will now have a personalized medicine. Thank you so much for a very, very patient listening.
Thank you so much, Dr. Srinivasan, for that excellent lecture and for making this so very difficult topic quite simple for all of us. We've understood for the benefit of the pediatricians that inflammatory bowel disease is not a single type of disease. They've got multiple complications or multiple permutations which need an individualized care and probably a treat to target. That is, you know the goals which you have to achieve and the multiple ways in which you can achieve these goals. Biologicals is one of them, steroids is one of them, and azathioprine is one of them. There are different ways and different stages in which you can use these. Like Dr. Srinivasan accurately said, you have to really personalize these medications for each individual. So it's complicated disease. And for the pediatricians, the word of caution would be that you have to always be in dialogue with your gastroenterologist, because we need pediatricians for the rest of the management of the patient. What about vaccination? What about routine infections, routine diseases? So definitely pediatricians and gastroenterologists should work in tandem for the better treatment and better quality of life of these patients. I think there is one question in the chat box.
So this is a 3-year-old boy with POIBD with multiple flares not responding to steroids and azathioprine. After 3 doses of infliximab also he continues to get flares. What will you suggest? No, we need to persist with biologic therapy. Cost is the problem that I see here. So that problem we need to solve it somehow differently. But if you are not responding to steroids as well as azathioprine at maximal dose and still continue to have inflammation which is not controlled, eventually you're going to develop some complication. So the sooner that you target it with a higher potent agent, the better. So there is no second thoughts. You need biologics. How we get to them is what we need to decide.
I think, Srini, they should do the genetic studies also, no less than 4-year-old child.
Yes,
True,
early onset.
True.
So that will give us a better clarity on what medications will actually work.
I think there's something more the child, because the response to biologic, like, the one which he showed, it's really amazing how they do respond, but young children are not responding. There's something different.
She's written genetic studies are negative. Dr. Vinita has written genetic studies are negative. So difficult situation when you have.
And that's the time I think we have to switch over to the other biologic, and then now combinations have come. I think now, like Srini will agree, even step up, step down words they don't want. They want upfront biologics, upfront biologicals, certain conditions, straight away biologicals. Don't even think of anything. But we are having problems all over the world. Response to biologic is not 100%. After all that, the percentage they'll give only will be 45, 50. That's all. Of the therapy, mucosal healing, that's the best. Some of them respond. That's I think Srini has nicely said, the individualized. Some of them don't respond from the beginning. They have issues. We'll have to do work.
The one question about complications that we come across in azathioprine. So generally azathioprine is very well tolerated. You have to monitor counts and you have to monitor for lymphopenia. So there are a few people where they are prone for azathioprine toxicity. So even at standard doses, sometimes they may develop bone marrow immunosuppression. So monitoring them for that is very, very important. You can have a very mild elevation of amylase or lipase, but they never develop a severe pancreatitis. 1 or 2 children are intolerant to azathioprine. The moment they put the drug, they vomit. So sometimes we counter that by using 6-MP. But apart from these, azathioprine is a very, very safe drug. Most gastroenterologists are very comfortable using. While adults use it at about 1.5 mg per kg, I think pediatricians are very comfortable using it even 2.5 mg per kg.
Just to add on to that, azathioprine, of course, the TPMT test can be done, but it is not a good indicator. You can have a normal TPMT test as well, and the child can still develop, because it's an idiosyncratic reaction, you can still develop a bone marrow suppression later. So always you will find that the gastroenterologist, when they're treating this patient, will go slowly, increasing the dose, not just give the whole dose at one go, and not very rapidly increasing the dose. That's one thing. Second thing, you always go by the symptoms of the patient, like Dr. Srini was saying. They may be otherwise doing well, the counts may be okay, but they may be developing severe intolerance, like vomiting, headaches, giddiness, no skin reactions or any allergic reaction that you can make out, but these could be harbingers of later complications. So like I said, you can circumvent that by going on to 6-MP. There's also one more question, one more part of the second part of the same question. How often have those led to the choice of biologicals as a therapeutic agent? That is, complications of azathioprine leading to the choice of biologicals. How often have you had to stop azathioprine and go on to biologicals because of side effects?
I think we've done that in 1 or 2 cases, not more. So the other options are to put them on something like methotrexate, especially if it is Crohn's disease. But yeah, we had to do that. I think I can recollect just 1 or 2 cases where we had to do.
Yeah.
So
one more question from Dr. Anu. Do you monitor drug levels for all patients treated with infliximab, or only when you get a poor response?
So the company which provides infliximab is sometimes happy to do it free for people who take it regularly. So I utilize that and I do monitor drug levels to see how well you're doing.
Okay.
So it becomes all the more important when you run into problems. But you also have to compare it, on the other hand, to know when people are doing well, how well still we are doing. So
do you have a level that you maintain, or you go by the clinical level, clinical response, or you have a drug levels that you would like to maintain?
So this measurement is being done at Mumbai at Hinduja Hospital. And so normally they want us to maintain levels between 3 to 7. So any level above 5, I think, is a reasonable level.
So even if the patient is responding very well, you would still...
No, I wouldn't step up. I wouldn't step up the
Just an
patient is
observation.
responding well. Clinical response and labs will help you to tell whether the patient is doing well.
Yeah.
But sometimes we have had to alter the dosing schedule of infliximab because patients, though they come for 8 weekly infliximab infusions, they become symptomatic by 6th week.
Okay.
So there are a couple of patients where we give them the same dose, but we make it once every 6 weekly, and that is one of the questions that somebody is asked. For some patients who can't afford, sometimes we give a 300 for once every 6 weeks and 200 for every 4 weeks, because you realize that this is not a strict dosing schedule, but it's more of maintaining trough levels. So if your clinical response is going down, maybe you need to do something different.
Okay, so the answer to one of the person's question would be that if the company is doing it for you, you can get it done for all patients. Otherwise, when you think there is a poor response or early relapse of these patients, then you can do your infliximab levels. Another question by Dr. Sheeta, can we not combine exclusive enteral nutrition with probiotics and inflammatory drugs? Right. So you have not underestimated the pediatricians.
No. So if they see the problem with exclusive enteral nutrition, I think I told you, I have about 17 patients whom I trialed on exclusive enteral nutrition. So there's one patient who completely attained remission, is doing well only on thiopurine. So most of the time what I find is they have clinical improvement, but they come back to you with a relapse. Okay. So you can't put them on exclusive enteral nutrition for a year or two. You can't keep sipping from a bottle for a year. So that is not possible. So same thing with steroid. You can't keep putting them on steroid forever. That's the reason why we have to resort to biologics.
So the question also is, do you have to do exclusive enteral nutrition as a standalone treatment, or can you do it as a combination with anti-inflammatory medication as well as probiotics? Because every little bit helps, is what I understand there.
I don't know how probiotics actually help, but there is no harm in trialing with anti-inflammatory drugs. But the one thing I want to tell you is that exclusive enteral nutrition is a therapy for Crohn's.
Okay.
And locally acting aminosalicylates are not useful in Crohn's disease.
Also, exclusive enteral nutrition nowadays, they do the not the complete partial enteral nutrition also is being tried in some patients. So this is probably an open field. Anybody can try and probably publish the results, and then probably we can all follow. Also, one more question from the same doctor: any role for growth hormone in growth failure for these patients?
So when we have there have been a couple of cases from the Gulf who come down for second opinions. So they have been referred by pediatric endocrinologists to whom they have been referred for growth hormone evaluation. And they have been referred because they felt that the growth will become better if you treat the IBD better. So if you treat your IBD very well, your growth will pick up. So without treating your IBD well, there is no role for growth hormone.
So point taken. Unless there is disease remission for the chronic illness, growth hormone cannot have its effect. So after the growth, the remission is obtained, and then there may be a role for growth hormone if the patient is actually reaching a stage where he's completing his puberty. Otherwise, I don't think for very young children, we usually don't go for any growth hormone therapy. They usually catch up with a period of 6 months to 1 year. They start catching up once the disease is controlled. Is that your experience also, Dr. Srini?
Absolutely. We have not had a child on IBD with growth hormone therapy.
Okay. The next question is, have you used tacrolimus as a medication for IBD? So please share your experience.
I have not used either tacrolimus or vedolizumab.
Okay. So tacrolimus, some people have been put on tacrolimus only when they're on maintenance therapy, especially when they have, I've seen one patient, but I don't think that patient was in very good remission with tacrolimus. It's not one of the first or second line medications that can be used in IBD. Definitely not the preferred one. It's usually used when nothing else works or they have side effects to most of the medications and biologicals are not being used. That's my experience. Dr. Malati, madam, do you have anything to add, madam? Madam is muted.
I think our patients, that's a small don't. I think our patients are responding well with that induction, steroids, maintenance, azathioprine, majority. And the next level, that's very small group where we are using all these combinations. So our Crohn's are able to manage. I think Srini also will agree. We are able to manage with the azathioprine and then we go to the biologicals. And certain we just do the upfront biologicals, at least during, especially during the pandemic, the new cases, because we didn't want to start steroids and most of them had moderate severe Crohn's. They were willing to start biologicals upfront. So we were able to manage. And then at the beginning itself, I had told them, take it for 2 years. It's no use, giving for one and all that. Plan it like that. And when we tell them, they plan it for 2 years and then you switch over to azathioprine, because that's the most crucial time, I feel, adolescents, when, we don't want them to get into complications. Very clearly, Dr. Srini said, because the biologicals work only during the inflammatory. I think pediatrician should remember that. It will not work once stricturing comes or, it's only during the period of inflammation it's going to work. So only when we start, that is a beautiful curve he showed. And once it becomes that, it's no use. Fibrotic strictures, all that is not going to be thing. So even the internal fistulas, we find it so difficult to give biologicals. But when they are models with a lot of inflammation, I think they do very well. So there are problems, I think, but if you follow them up, infections like TB, I think you've shown very nice. Tuberculosis, ruling them out, and you will see. Our chief used to say, only when you see complications, that means you've had experience. If someone just says, I've not seen even one complication, you won't even listen to that person. So Srinivas, when you have complications, that means you've seen a number. I was also surprised. I had screened one patient so much for TB, and then afterwards I got a call, madam, I've developed effusion and tuberculosis. And you feel bad, but it can happen, but still you feel, oh, why did that person get it? So I think only when you see a complication, when you see so much, then you're able to. Tacrolimus, even I have not started, not given, and I think, like you said, it may be required. There are people are talking whenever they come from abroad, they talk. But,
yeah. So thank you, madam, and thank you, Dr. Srinivasan. I think the questions are done. So just concluding. Yes.
I cannot talk. I cannot write. That's why. Thank you, Malati madam and Srinivas for excellent talk. One doubt about this extra-intestinal complications we learned about in the hepatic joint and skin and all. When we learn about inflammatory bowel disorders in the adults, as you go, the age goes down, especially early onset, very early onset and all. Is it less significant? You didn't mention about those complications.
Extra-intestinal manifestations in our studies, we had Crohn's was 25 to 30. Our complications, EIMs, which we say, they can come before the onset of the bowel. They can come along with the bowel. They can come even after the bowel is quiet. So they can come any point of their life. And we do see EIMs are common in children. Actually, for us, it is oral ulcerations, arthralgia, anemia. We have seen even sweet syndrome. We've seen skin manifestations, but our most is our oral ulcerations. That's why pediatricians, that's the way they pick up and they send. The recurrent TAF, though acute TAF is so common, but oral ulcerations we have seen. With erythema nodosum, we've seen arthritis, we've seen, I think Dr. Srini has also mentioned this child coming with it. We are seeing EIMs, children.
Also uveitis, a lot of
uveitis, but the proportion of the highest was oral, then it was skin, and then anemia came higher up. Even that is a thing. Srini, you have anything else to say? These are the most common. One case of hepatobiliary, one case of thing we will have seen. Otherwise, EIM as common as in adults. Actually, we picked up more the percentage when we compared adult data and pediatric data from India. Our proportion was higher too for the number. Was higher.
Thank you, madam. So thanks again to Dr. Srinivasan for that excellent lecture, and thank you, madam, also for your valuable points. Thank you to IIP Thiruvananthapuram and Dr. Prashant for staging this show for today. It has really been an excellent array of talks and discussion. So thank you, and over to you, Dr. Prashant.
It was actually a really engaging discussion as well as the enlightening talks. So we're grateful and thankful to the esteemed speakers and the chairpersons. And I would like to thank all the delegates who have attended till the end of the discussion. And now it is time to conclude the program. So may I invite our executive board member, Dr. Rosemary, to propose a vote of thanks. Go to Dr. Rose.
Thank you, sir. On behalf of IIP Trivandrum, I take this opportunity on this World IBD Day to thank those two illustrious speakers we had today, Dr. Malti Satyashekar, the consultant gastroenterologist from Rainbow Children's Hospital, Chennai, and Dr. Srinivas Shankar Narayan, sir, from Apollo Children's Hospital, Chennai. Both the sessions were quite enlightening. I thank the chairpersons, Professor Dr. Lalita Gelas, Madam, Principal Sri Gokulam Medical College, Yarmood, and Dr. Geeta M., Consultant Pediatric Gastroenterologist from Aster Medicity, Kochi. Your chairing the sessions made it all the more lively. And I take this opportunity to thank Dr. Prashant K. sir, who took great initiative in setting this program up. And it is totally his hard work in making this happen. I also thank Dr. Mohan Shenoy for hosting this webinar platform, Zoom platform. And I would like to thank all the senior colleagues and the other junior members and friends for joining this session and making this successful event. Thank you all. Wish you all good night.
Thank you.
Thank you, Prashant. Thank you, Srini. Thank you, Geeta. Thank you, Dr. Vijay Kumar. Thank you, everyone.
Signing off. Good night.
Good night. Signing off. Thank you, Rose. Bye.